Okay, welcome everybody. I've had a single start, so thanks everyone. It's slightly odd with people being disembodied. In fact, it's slightly more nerve-wracking talking to my screen and seeing my face in front of me than talking to 250 people in a lecture theatre. But a big welcome to everybody. I'd like to first welcome to this year's the 2020 Marsden Lecture. I'd like to welcome some friends from the NHS. And then some others who I'll name check. So I'd like to thank Sir David Sloman, who's going to follow me up with some opening remarks before we have David Feinberg. I'd like to thank my boss, Caroline Clark, who's with us, Dominic Dodd, the chairman of the Royal Free, Tara Donnelly, who's the chief digital officer of NHS Digital. Then I'd like to thank some colleagues from the charity, so particularly Judy De Winter, the chair of the charity, and John Spires, who's the new chief executive of the Royal Free charity. I have two hats here. I'm the chief medical officer and deputy chief exec of the trust, but I'm also a trustee of the charity. So both the organisations are represented in our panellists for today. Then the final person I'd like to name check is Professor Emma Morris, and I'll tell you a bit more about Emma shortly. So I'm just going to say three things because you're much more interested in hearing the two Davids than in hearing me. But the first thing is I want to tell you a bit. Everyone's been to these lectures before, and you know the routine. We talk a bit about the history of the Marsden Lecture. William Marsden was an amazing character. He founded the Royal Free Hospital. He also founded a smaller cancer hospital somewhere in central London, which apparently is quite well known. And we're very proud with that connection. When you hear any of us speak about the Marsden, we do it with pride because we think the concept of the Royal Free Hospital, a free hospital where poverty and sickness were the only passports, is something we started at the Royal Free and then caught on and became the NHS. And William Marsden was walking on the road in London and he found a both poor and sick young lady on some church steps and took her in, and the concept of a free hospital was started with that. The first hospital was in Hatton Garden, right in the kind of centre of town in the city, and we've moved to Leafy Hampstead since then. But I think that link between science and medicine and philanthropy is in some way what we're all about, and I hope what this evening's all about. So the second thing I'm going to talk about is this is all a bit different this year, isn't it? COVID's came along. When we had the lecture last year, we were all in a room together. But this year we can't do it like that. Sometimes the world during COVID is difficult, but actually this presents us with an opportunity. One, to refresh the way we do things, but two, make it available to a wider audience. So we've got an invited audience from people who are friends of the charity, people who are friends of the Royal Free, and some of our kind of NHS and our innovation partners like Google here tonight. But with the opportunity presented us by not doing things face to face, as well as an invited audience on Zoom, we've got hopefully a very big audience on YouTube, which we kept for posterity. So that presents us an opportunity to take this out to more people, and for more people to get the opportunity to hear David speak, which we're all very excited about. The other thing the kind of final thing really is to talk about the kind of generosity of the charity and the opportunity that this presents to us, and I think there are two tiers to that. So wearing my trust director role, the charity have been fantastically sick for years and years and years, but particularly over the last year during the COVID crisis. Some of the stuff they've done to support staff in what have been very, very, very tough times has made a difficult job considerably easier, and we're enormously grateful for the charity for that support. But wearing my trustee's hat, we're also fantastically grateful to the people who've given money to the charity. It's a tough time at the moment. It's a tough time for the economy. It's a tough time for the country. But actually, it's a time when people have been more generous, and that's giving us opportunities to do some really really spectacular things. We've just got a building going up, which when we do this in real time, you'll be able to see our Institute of Infection and Immunity and Transplantation. And we hope this is the first of these clinical academic institutes, not a kind of point in time. So we're delighted about this. And what we've done over the course of this year is plan that the Marsden Lecture is not just something that we do once a year for an hour and a half and then feel good about, but it's part of a program where we have a conversation with our friends about the way the public sector and the charity can come together to take forward healthcare, but also to take forward knowledge and discovery. And in that spirit, I want also to welcome Professor Emma Morris to make this more than just a one-off event. We're starting a series of talks which we're going to we like a good pun. We're going to call free speech, and free speech are going to be monthly lectures, short talks with a Q&A afterwards, given by clinical academics who are really in the interface between discovery and making a real difference for patients. I'll make her blush. We've chosen Emma first because she's very, very good at this. She's a brilliant communicator, does a lot of work explaining science and genetics in schools, and is married to a school teacher. So has a really good pedigree for doing this. But she works in an area of medicine, which when I was at medical school, felt like science fiction. Felt like something that no way you could do this. So she works on stem cell transplantation in single gene disorders in immune deficiency, and is also involved in gene therapy. So she's able, at an early level, to give genes to people with a single gene disorder and effectively cure people. And that's the kind of stuff that was science fiction when I was at medical school. And I'm reasonably old, but I'm not that old. So this is a tremendous advance. So I'm really looking forward to the first free speech talk when it comes along on the 14th of December at 6 o'clock in the evening, and we'll send out to the delegates from this how to access that. And we're going to give monthly talks for 10 months of the year, leading out Christmas and August, in preparation for the next Marsden Lecture in November next year, where I hope a number of us will all be in the same room. Okay, the final thing I'm going to say is you do have an opportunity to ask questions of David of David Feinberg after his talk. There's a Q&A function in Zoom, which the invited audience on the Zoom chat can participate in. So if you ask your questions on then, and then they'll be moderated, and I'll chair the Q&A session with David, and I hope we'll have 20 minutes at the end of David's talk for some very energetic and searching questions. Okay, so that's all I want to say for the moment, and I'll hand you over to Sir David Sloman, who'll give a further introduction to David and give us some of his own reflections. Thank you, David.
Thank you, Chris. Can I just, people can hear me and I'm on the screen, is that right? Thank you, Chris. Thank you very much for that introduction. And can I thank you all for inviting me back here to the Royal Free, where I spent 10 very, very happy years as a chief executive and enjoyed every single one of them. But of course, those 10 years were only one of the 19 decades that the Royal Free has been open and providing care and services. It comes up to its 200th anniversary in 2028. And what I thought I'd just dwell very briefly on this evening, given the COVID times in which we live, is the contribution that the Royal Free has made over those 190 years in the field of infection prevention, control and infectious medicine, because it's worth remembering that the Royal Free, it was founded in 1828, but it received its royal charter in 1836 as the only hospital that stayed open during the cholera epidemic. So that's where infectious disease all started at the Royal Free, back in 1836. In perhaps a slightly less savoury way, in 1846, no hospitals across London were willing to admit people with venereal disease, but not the Royal Free. The Royal Free opened a special ward to look after people with syphilis and it came under much public attack, but the government responded with the words, "Whilst the hospital has accommodation, it takes in all it can. And the more wretched they are and the more diseased, the greater their claim on this charity." So again, another proud moment in the Royal Free. And of course, then if we move forward over 100 years, the Royal Free was at the very forefront in the contribution to the UK's response to the AIDS and HIV epidemic, which is symbolised, I think, by the Ian Charleston AIDS and HIV Centre at the Royal Free, which was open and put together with much benevolence and charitable donations, which again is a real marker of the partnership that the Royal Free has enjoyed. And of course, we celebrated its 25th anniversary in 2017 with an absolutely wonderful event at the Actors Church in Covent Garden, when I had the pleasure and the most frightening experience of having to speak after Sir Ian McKellen. So in terms of great moments, and as I said at the time, my NHS presentation skills training was not quite up to match to that world-renowned thespian. Of course, not long after that, the Royal Free also led the response to the Ebola pandemic, and without a single shadow of doubt, it was the care of the nurses and the doctors at the Royal Free Hospital which enabled us to save the lives of those 3 nurses who were flown home from Sierra Leone, which brings us right up to date now with where we are with the response of the Royal Free to dealing with this truly dreadful COVID-19 virus. And I think a response which has been humbling, actually, and has been there for all to see on those first 2 episodes of the hospital programme shown on BBC. But now I'm an avid viewer into episode 2 of the 6 episodes which are currently on show. So in all seriousness, it has been a remarkable hospital with a remarkable history. And I've touched on cholera, I've touched on syphilis, I've touched on AIDS, I've touched on Ebola, I've touched on COVID. The contribution has been extraordinary. The legacy has been enormous, but the future is even brighter. And I think as I move into the future, it is probably a right moment to hand over to somebody who will, of course, be leading us into the future and the way that big data will undoubtedly underpin and plan the things that we do. So from one David, thank you very much for the invitation and enjoy your evening as I hand over, I'm not sure either directly or via Chris, to David Feinberg for the main speaker of this evening. Thank you.
Wow, I got chills. It's an amazing honor to be invited to do this, and I desperately wish that we were in person, but I commit that we will get back together at one point, and I look forward to meeting with all of you in person. What an honor to be a speaker named after somebody who, to me, as I've learned about him, really embodies patient-centeredness. So let me give the answer to my talk before I start. The role of health technology and innovation in delivering better care. To me, the role of technology in delivering better care is to help caregivers, whether those are people taking care of themselves or professional caregivers, just take better care. Fundamentally, healthcare to me is people caring for people, and we certainly hope that our tools help those people in that effort to care in the same way that Dr. Marsden did. So Chris had asked me to do this talk and to go over a little bit of my background. So I'm happy to do that. I stand on amazing shoulders of folks that have been mentors to me and teammates to me. And so I want to do this in the most humble way. But it really takes me back to 2 patients that I think helped form my thinking around patient-centeredness. I'm trained as a child psychiatrist, an adult psychiatrist, and also was board certified in addiction medicine. But in my training in child psychiatry, in my last year of training, which was about 27 years ago, I saw this young boy, 12 years old, and I was in Los Angeles at the University of California, Los Angeles, and this young 12-year-old came in with a new onset psychotic disorder. He was seeing things and hearing things that weren't there. And he came from Las Vegas. Las Vegas is about a 4-hour, 5-hour drive to Los Angeles. And he was brought in by his single parent father. Mom had left when this young boy was young. And dad was a used car salesman. He actually sold Cadillacs in Vegas and fit the kind of stereotypic used car salesman from Vegas. And at that time, because I was still in my training, I had a very, very small office. It was so small that I actually had to close the folding chair when I opened the door to let the dad in, and then I'd close the door, open the folding chair, and dad could sit down. And UCLA was a great training place, and I thought in those days that I was super smart. And I started to talk to the dad about neuroleptics and neuroleptic malignant syndrome and dopamine reuptake and first onset psychosis and ventricles. And the dad looked at me and he asked a really important question. He asked me, does he need to build a room out back for his son? And I started to cry. We had a 1-year-old at that time. She's now 28. That's why I know it's 27 years ago. And you have these hopes and dreams for your own family and your own children. And I realized that the trajectory of his life had just changed dramatically. And we didn't need to be talking about neuroleptics. We needed to be talking about what this meant now for a single dad to have a son with a serious mental illness and how that changed the trajectory of their lives together. He taught me that we need to talk to people in a way they understand. And that's been something that I've been focused on, I'd say, for the last 27 years. And I hope as we spend some time together, you'll see how I think that really comes together in this amazing opportunity I have now with Google. Another case was a few years later, and it was a 3rd grader who wrote in her haiku poem that she wanted to tie yarn around her neck and kill herself. And these days, we're before cell phones, and so the teacher read the haiku poem that night while she was grading papers. The next morning, she alerted the principal called the mother called the father, who had never been interrupted at work by his wife, he told me. And this was Los Angeles. And Los Angeles is all about who you know. And these people knew people. So because they were able to pull strings, they were able to get to see me within 3 weeks. And when I sat with that family and the little girl, and she did very well with treatment, it became really clear to me that if your 3rd grader wants to tie yarn around her neck, you need to be seen today, no matter who you know. And that access to care has to be one where it doesn't matter who you are or what's going on, kind of back to Dr. Marsden. We as healthcare providers need to say, we've been expecting you and we'd like you to come in today. And we have to build a system that's not provider-centered, but rather patient-centered to get to that. So I was having a lot of fun at UCLA, taking care of patients. And I got asked to do a couple administrative roles. This was a big turning point for me. So they asked me to run a child psychiatry outpatient clinic. And what do I do with those kinds of things? I call my mom and dad. And my mom said, well, I don't think it's a good idea, because if you do administration, I'm sorry if there's some background noise here, but that's Zoom. If you do administration, there's going to be less time for you to care for patients. I said, well, Mom, you don't get it. I'm going to be working with 2 or 3 doctors. So there's going to be an ability for me to provide that care to even more patients. We kind of went back through it. I decided to take on that administrative role of running the child outpatient clinic. It went really well. And I'll fast forward to a few years later. I have the responsibility of running the psychiatric hospital at UCLA. And the person running all the UCLA hospitals leaves unexpectedly. And the dean comes to me and he says, listen, we just borrowed $75 million to make payroll. We were not in good financial shape. We are building a new hospital because our old hospital had been damaged by an earthquake, a big medical hospital. And this hospital is $500 million over budget and 5 years delayed. If we would do a search for a real CEO right now, nobody would come. So would you do it? So with that vote of confidence, I said, I have no idea what the job is, but I'd be happy to do it. And went from half-time child psychiatrist and some administrative roles in psychiatry to running the UCLA health system. The UCLA health system is world-renowned. US News and World Report ranked us as the third best hospital in the country, do more organ transplants than any hospital in the country, diagnosed the first case of AIDS, invented the PET scan, Herceptin, the nicotine patch, the list goes on and on. So now I'm quote unquote in charge of this large medical center where really my expertise was in treating patients and families with mental illness. So I'm totally overwhelmed and thankfully have had some amazing mentors. And a mentor of mine says, okay, with this new job, you need to find one thing and focus on it because thousands of things are going to come your way. And if you do this job for 3 or 5 years and you try to get engaged in all those thousands of things, you will not move the needle. So with that in mind, I did what I know best. And that was go sit and talk with patients. And so I wandered the halls of the UCLA hospitals, the parking lots, the waiting rooms, and I'd spend about 2 hours a day sitting on patient beds and asking them, how's the care? How's it going? Well, I learned that yes, we were ranked third in US News and World Report, but you know, the hot food was never hot. The cold food was never cold. We were short on bedpans. We didn't have enough wheelchairs. And actually, most patients told me that once they got treated here, they couldn't wait to get out. It was as if our mission was, we're UCLA, aren't you lucky you get to see us? And so with an amazing team, we tried to turn that around. And the one thing that then I picked, thankfully, hearing my mentor in my mind, was let's focus on patients. And this was long before people were talking about patient satisfaction. Long story short, we were ranked in the 38th percentile in patient satisfaction on questions of would you refer us to a friend or rate us on a scale of 1 to 10. So yes, we were ranked highly according to the beauty contest like US News and World Report, but when you talk to patients, 2 out of 3 would not refer us to a friend. In a short period of time, we turned that 38th percentile into 99th percentile. We became the highest ranked hospital in the United States among 6,000 hospitals on would you refer us to a friend or rate us on a scale of 1 to 10? And the way we did it was actually one patient at a time. That every patient that came in, we said, well, why don't we introduce ourselves? Why don't we provide same-day access? So anyone who calls, we'd say, instead of hello, press number 6 or press number 4, we answered the phone, we've been expecting you, would you like to be seen today? Back to that little girl who had to wait 3 months to get in. So we tried to also explain things in a way that people understand. So anybody who entered a patient room, not only would introduce themselves, they'd ask permission before they did anything. May I check your blood pressure? And when they left, they would tell you what's coming next. Back to let's explain things in a way that people understand. I remember one time meeting with the housekeeping staff, and we wanted our housekeeping staff to be more than just housekeepers. We wanted them to be part of the healing team because we felt everyone was part of the healing team. So we'd give them tidbits of information. For example, and this one might not play to this audience, but it happened to be the anniversary of Little League. Little League is baseball for little kids. Think of it as a soccer league, and it's a big deal in the United States. That day was the anniversary of Little League. We tell that piece of information to our housekeeping staff. So when they're in the room at 2 in the morning cleaning somebody's room, if there had been a spill, they would introduce themselves. They would say, is it okay to clean the room now? And then they would say, hey, and did you know today is the anniversary of Little League? Because what we wanted them to do is to create a connection every time one of our staff members came in touch with a patient. So it was really, really gratifying to see a big academic university become, in my humble opinion, incredibly patient-centered. And then I got a call. There's this place in central Pennsylvania called Geisinger, and it's probably one of the few examples of healthcare in the United States that's as similar to healthcare in the NHS, where the most of the care in the United States is based on a system we call fee-for-service. So the more patients that we saw, the more money we would make at places like UCLA. But there weren't particularly incentives for us to keep people out of the hospital or healthy. because the way the revenue came was you got paid for what you did. Well, this place called Geisinger, and there's a few others in the United States, had a different approach to care, and there's some historical reasons. But not only did it provide care, it provided the insurance for care. It was the payer for care. So patients that came to Geisinger not only had Geisinger insurance, but they saw Geisinger doctors and nurses, and they went to Geisinger hospitals. So if we're paying for the care, now all of a sudden we have a very strong incentive to make sure that the people stay out of the hospital or get the right kind of care they need at home, because now we're aligned in driving the cost of care down, the quality up, so people stay healthy. And it's a particularly unique part of the United States where there's not a lot of in-migration or out-migration. Families have lived in the same communities for 8 or 9 generations. So I went to Geisinger with the intention of learning one thing that I thought would really help me in my career. And that was to learn the insurance business, to understand risk and risk adjustments and actuarials. And I did. I got to Geisinger and I learned that. But I learned something that I had that I wasn't prepared for, that was much, much more important than learning the insurance business. I learned about how to love a community. And I think it's very similar. I mean, it's very unusual when I talk to colleagues in the United States and say, do you know that when the Olympics were in London, the opening ceremony celebrated the national health system? And we chuckle because it would never happen here that Blue Cross of North Carolina would be celebrated at the opening of the Olympics in the United States. We just don't have that love affair that goes back and forth. And what Geisinger has done, and I do think it's because of the way the system is set up, there's a mutual respect where these organizations have grown up together and taken care of one another. To me, very similar to the groups that, to the relationship between the citizens and the NHS. So when you say we want to improve quality and decrease cost, it's a very, very easy discussion in these kinds of places. So what did we do there with this kind of freedom to not worry about how many patients are coming in? Well, one thing we did was we saw a lot of patients with type 2 diabetes, not only among our staff, but among the community members. And this guy named Hippocrates a long time ago talked about food as medicine. And if you say to patients with type 2 diabetes, you need to diet, have good diet and exercise, but they don't have access to the food or access and ability to do that exercise, you end up treating patients with medications and have the multiple complications of diabetes. So we said, what if we started a fresh food pharmacy? What if we said to those patients that have any type of food insecurity, if you have type 2 diabetes, here's food for you to take home every week with recipes. And if you're living in a motel and you need a hot plate or a spatula or a microwave, we give you that too. And we want you to have enough food for you and your family and do a lot of diabetic and nutrition education so that you can be successful with those food programs. So we started with 8 patients. It was amazing. We saw one patient who we had spent, because we were the insurer, $160,000 on his care before he was in the program. 3 months into the program, his medical cost to us dropped to $40,000. So we said, wow, we're really onto something. Today, Geisinger, and I don't have up to date because I've been gone for about 2 years, but I think it's around 5 million meals a year are provided across the system to patients and their families to treat type 2 diabetes instead of or in addition to medication. You know, what we saw was that the hemoglobin A1C, which is a measure of your blood sugar over the last 90 days, dropped about 2 points. That's more than you need to get approval for an FDA medication. It's more than a lot of the medications decrease the blood sugar. So it was a resounding success, and it really drove the idea that you need to be engaged and take care of people, explain things in a way that they understand, and in some cases provide them with healthy, nutritious food. The other thing we did on the other end of the spectrum, which was pretty high tech, was we thought, well, what if we looked at everybody's genome? What if we looked at your genome and were able to tell you in advance whether you or somebody in your family has BRCA or has an autosomal dominant disorder that is going to make it highly likely that you're going to have a stroke or a heart attack later on in life because of high cholesterol, or you're going to have potentially a bad reaction to anesthesia. Now, normally when you ask people to volunteer for a genomic study, you get about a 50% consent rate. Because of the love between the organization and the community, we got 90% of people to say yes, and created the largest biobank in the world of genetic information combined with phenotypic information. And because we were also the insurer, we had the payer information. And we also had one of the earliest adopters of electronic health record. So we had a longitudinal record of these folks, and it made, in partnership with Regeneron and others, some amazing discoveries that we think is going to help healthcare worldwide. So really, really proud of my time at Geisinger, where I learned about loving a community, and we did these programs because that's what the community needed. And we're starting to see, thankfully, in the United States, this concept of value-based care spread across, and it's not just in pockets now like it was 4 or 5 years ago. Now, we had a lot of data there, and places like Google, and that's how I got in touch with the Google people, kept coming to Geisinger along with other tech companies, and we kept thinking about what can we do with our data in a way that could help our community and help our patients. And then Google called and said, well, we're trying to put together a health team at Google, and would you be interested? And to me, again, I went back to calling my mom and dad, and at this point have an amazing, well, I did back then too, an amazing wife that helps me with these decisions. And when you think about it, if my career has been about explaining things in a way that people understand, and making sure that people have access to care, get in right away, you know, Google search has the potential to do both of those things. So as a practicing physician for now almost 30 years, the first 10 years of it, when there was no Google, it's very paternalistic. I, back to that case of the boy with the psychotic break, knew all the information, at least the technical information. The first 10 years or so Google, I think there's definitely a lot on the internet, and as a provider, there were patients that would come in with printouts and you were like, stop going to Dr. Google. But over the last few years, as we get more authoritative information and partnerships like we have on knowledge panels with NHS and Mayo Clinic in the US, we hope we're providing people with better answers as they're trying to discover what's going on in their healthcare. So I thought, this is an amazing opportunity to be able to scale getting information out to people and making it accessible. When you think about it, Google doesn't have hours. We're open 24/7. So I joined the Google team just about 2 years ago and would love to share with you what we're trying to do. And I will divide it into 2 sections, but ultimately it comes together because it's around one person, one family, or one community, or in the case of Google, a one world. So on the consumer side and the clinician side, so those are the 2, but they come together. On the consumer side, we're thinking about populations and what can we do to help populations? And COVID is a perfect lens to tell you the things we've done that we hope are helping populations. We've launched this thing called community mobility reports that have been downloaded now millions of times around the world for policymakers to see, are people social distancing? Are they staying away from the supermarkets? It shows how, in a privacy-preserving, anonymized way, how communities are doing as a way to help predict, are we going to have a spike, or is our policy working or not working? With partnership with Apple, that we're very proud of, created an exposure notification tool that allows anyone with an Android phone or an Apple phone, if they opt in a privacy-preserving way, to know whether they've been exposed to somebody who's now positive for COVID. So think about it. If I'm positive for COVID, I come home from work, I can tell my family, but I can't tell the person I sat next to on the bus. If that person had the app and we were in contact for 15 minutes in under 6 feet of distance, and now I'm positive, that person would then be notified you've been exposed to somebody. They're not told who, and we don't keep any of the information, but that person could be told they've been exposed. So that we think is an important one, but you could see how that can help communities. We've also launched, and this is now just in the US, but soon to be more broadly, a symptom search trends tool. So we took 420 symptoms, medical symptoms that people are looking for, seeing if that can help us understand where COVID may be next, or other parts of the COVID illness that we're not aware of. So I was just reviewing it a couple of days ago, and I'll give you kind of some of the cute things that we found. Over the last 6 months, there's been a high increase in searches for acne, right? And that's because if you wear a mask, you get acne. So we've seen that. It seems to be not seasonally related. It's more than we've ever seen before. And there's a corresponding decrease in searches for broken bones, which makes sense. There's less people outside. There's probably less snow skiing. There's less risky. There's less driving. So broken bones have gone down and acne has gone up. But you could look at decreased smell. You could look at decreased taste. You could look at cough, etc. Actually increased hair loss. Increased dandruff. Are people not showering as much or cleaning as much as they work from home? So all of those things are in some way, some of them are kind of parlor games, and some of them I think can give us really great information. We also want to give individuals, in addition to populations, tools to make better decisions. We have loved our partnership with NHS, and the authoritative information drives folks right to the NHS websites. We've launched screeners, and we've seen a lot of people coming to Google for questions around depression, anxiety, PTSD. So we now have screeners where if you were to Google anxiety or depression, you get a knowledge panel, which is curated authoritative information, most of it in the NHS, in the UK it's NHS, and a self-screen checker. So you can check for yourself. These are not diagnostic, but they're clinically validated where you are along a spectrum of anxiety. So as you make that discovery of what's going on, we want to get people into action. So we're bringing tools that allow people to take that next step and ultimately close the loop so that when they take that next step, they can then share with their loved ones what happened. So that's what we're trying to do on the consumer side, both with COVID and with general conditions, and in some cases, more complicated conditions. I think we have 250 knowledge panels, if I'm not mistaken, with the NHS, 251. It was 250 and we added COVID. Now, we also want to bring healthcare providers the great technology that Google has developed on the consumer side. So when you think about how wonderful search can be when you're looking for something, what if your doctor or nurse or social worker is looking for something about you? What can we do to make it easier for them to find? So these electronic health records, to me, have been fantastic because they have digitized the paper. That's great. We did not have that before. What we need now are tools to make them work so the doctor doesn't have to spend 70 clicks to find a Tylenol, but rather can spend time at the bedside. We think bringing Google technology and overlaying it on top of the electronic health record would give doctors and nurses that ability to be able to find what they're looking for about you so they can spend more time with you instead of worrying about where that information is. A great example of this is our work around predicting who's going to go into kidney failure. So kidney failure is a high mortality disorder. It oftentimes happens to people that are in the hospital. In your hospitals and your trust, there are rapid response teams, which are teams that get notified if somebody in bed 6 is looking like they're not doing well. So what we launched was a mobile app that allowed that rapid response team to get just one notification. And the notification was the patient's creatinine went up. Creatinine is a measure of kidney function. So if this creatinine number goes up and you're in the hospital, you want that team to know that, hey, you may be going into kidney failure. By developing a very, very user-focused tool for these rapid response nurses and doctors, we saw that the time to diagnose acute kidney injury went from 4 hours to 14 minutes. There were 30% less patients that had cardiac arrest, and the cost of care went down by 17%. And we were just looking at creatinine. So then we said, well, what if we took this Google tool, that's great, and added the Google technology around machine learning and AI. So instead of just looking at creatinine, we took that same concept, and this was in partnership with our Veterans Administration in the United States. We looked at 600,000 variables per patient in real time in their electronic health record. So instead of creatinine, we gave actually the entire medical record, everything in it, to the computer. And the ability to diagnose acute kidney injury now went from 4 hours to 14 minutes with the app. It now went to -2 days. 48 hours before any clinical symptoms were seen, we were able to predict with 90% accuracy who was going to end up on dialysis. So it's really the beginning or the dawning of anticipatory medicine, where we're going to be told this patient who looks really good in the waiting room is going to be particularly ill in 2 days. What do we do? How do we handle that? We need to figure that one out together. But it's really exciting to see these tools now in the hands of people, and then you apply the machine learning and the AI, and you start to see things that you really couldn't see before. And speaking of seeing things, I think computer vision is another place where AI is spectacular. In the United States, for mammography, you can get your mammographies pretty much whenever you want. There's not a long wait, but they have only one reader, meaning there's one person that looks at your mammography and gives you the results. In the UK, sometimes there's a delay in getting your mammography, but there are 2 readers that read mammographies. And if those 2 readers don't agree, it goes to a tiebreaker. So you probably get less, you do get less mistakes in the UK because you have potentially 3 people looking at your mammography. So we thought, what if we could take our computer vision and train it around mammographies? Do you have a lump? Is it cancer? Is your mammography normal? And what we found in the United States was our tool was able to decrease, and I might get these numbers backwards, but I think I got them right, false positives, meaning you have a lump and you don't, by 5%, and false negatives, meaning your mammography is normal and it's not, by 9%. I might have superimposed those 2 numbers, but let's say in the single digits, but significant single digits, we were able to decrease both of those mistakes. That's amazing. In the UK, we actually were able to perform as well as the 2 readers in the tiebreaker. So what if we could speed up mammographies in the UK by saying, well, what if you had 1 reader and that person also had it read by the computer? And if those 2 didn't agree, the person and the computer, it would still go to a tiebreaker. So you'd still have multiple eyes looking at your mammography. You could speed things up because you would need less people working on mammography. So those are the kinds of tools that we think are really great to put in the hands of caregivers to speed care, improve care, and make care more equitable. Dr. Marsden said, poverty and sickness are the only passports, as Chris brought up earlier. And he sets up, and I think this showed that he didn't have a good marketing team in the beginning, but he sets up an institution that he calls the London General Institution for the Gratuitous Care of Malignant Diseases. It just rolls right off the tongue. That eventually becomes the Royal Free. And he also then goes on, as Chris mentioned, to establish a cancer hospital. You know, I tried to learn as much as I could about Dr. Marsden in preparing for this, and I found that there's a book available on him, but it costs $891 because I think it's his old papers or something like that. But I did find that it's at UCLA And I'm doing my best to actually being able to go see the book for $891 about Dr. Marsden. But when you take a step back, it's really about, it's an amazing example of patient-centeredness, about what do the patients need and how can we help them. And building a hospital, I would say, is a technological advance. But the hospital's purpose is to help the care of that young woman that he found on the steps that he brought in. So I think together, our work could and should make Dr. Marsden very proud. We just need to remember that the patient, and I mean when I say patient, also their family and their communities, but that the patient, and I mean every patient, regardless of their ability to pay, deserves care that's safe, that's high quality, that's culturally sensitive, that's affordable, that's accessible, and understandable. It's been a real privilege for me to spend some time with all of you. I want to thank you again for inviting me. I'm humbled and honored by this, and I wish all of you safety and health during these challenging times. And I do think we get some time for questions. So thank you very much.
So thank you very, very, very much indeed, David. It's a privilege to have got to hear all that. It's great, and I expected this, but it's great to have a story about a patient at the middle of this. It's really obvious, you know, in three organisations how the patient is in the middle of things. So delighted to hear that. I've got a question first, and then we've got 4 already in the Q&A. So I'll probably group them into I'll group the 4 on the 4 on the Q&A into pairs. We've got loads now. So the first question I'll ask is what do you think? You talked a bit about AI, but David, what do you think what do you think will be the impact of AI on healthcare? So how do you think healthcare will change as a result of AI when we've really reaped all the benefits?
Yeah, so thanks for that question. Let me give another example. If you go to a dermatologist, if you go to a primary care doctor with a rash or a nurse practitioner with a rash, they get the diagnosis right about 50% of the time, right? They don't see a lot of rashes. They're not sure what it is. It's a 50-50 that they get it right. If you go to a dermatologist, the accuracy goes up to 90%. So they get it right way more times than the primary care doc. It's their specialty. So we showed that our tool on computer vision, looking at rashes, when you give that tool as an assist to a primary care doc or a nurse practitioner, diagnostic accuracy goes to 90%. It's as good as specialty care. So what is AI going to do, I hope, is going to make care more equitable. There's places that don't have dermatologists, but now we can have your primary care doc be almost as good as a dermatologist. And there's places around the world that don't have access to care at all, where you start thinking about, well, what if the phone did this on its own? So I think AI has the ability to improve the quality of care, to improve the equity of care, and improve the breadth of care, that it'll be more available in places where it wasn't before. We got to be super careful though, because that skin tool, did we look at people with different shades of skin? The tool that I talked about around AI and acute kidney injury that we did with the VA, amazing research, really, really exciting. 93% of the patients in the VA are men. So how applicable is this to women? So as we build these data sets and we do the AI, we've got to be incredibly transparent around how did we get the information. We have to make sure we're not perpetuating biases that are already in healthcare, and that underrepresented groups, women in healthcare, people of color, people who don't have access to healthcare, we have to make sure that we're not perpetuating those inequities. So it's going to be tricky, and I think we need to be transparent and really above board on what we're doing, and clear where there's limitations. So that's my sense of where AI can have, though, a profound impact in healthcare.
Thanks, David. So I'll group the questions into threes. So I'll talk about, so I'll answer the first three. Two of them are linked together, really. So the first one is from Bimbi Fernando, who's one of our transplant surgeons, which is, how can big corporations such as Google that have access to and own big data earn the public's trust that their actions are genuine in health promotion and benefit and not purely for corporate profit? I'll ask you three. So there's that one. The third question links to that, which is is from Anna Cogger from the charity, which is, to what extent will people's concerns about sharing personal data impact Google's vision for improving healthcare? And then the third question is also from Anna, but is slightly unrelated, which is about, she says, it's amazing to have had such success improving health outcomes with simple interventions like healthy food when you're at Geisinger. And she said, has this been taken up by other hospitals in the US? And if not, how do we overcome the barriers to adoption? So the first two questions are about, I suppose, trust and data. And the last one is about spread of good practice.
Let me take them in backwards order. The spread in practice on those things is, the more we've seen systems in the US move to value-based care, the more they've started to say, wow, we got to worry about housing. Wow, we got to make sure people have transportation to get care. Wow, we got to worry about food. So the push, and you know what, we've had quite a political season here in the US, and there's been multiple things that you hear in the news. This administration that's currently in place, the administration before, and the administration before, and I'm assuming the next administration, has been very, very consistent, and I think excellent about pushing toward value-based care. So despite all the craziness that we're hearing, there's been consistency there. And I do think we're seeing that being taken up. And as more and more folks are now responsible for all of your care, it starts to make sense. Well, why would we give an expensive medicine and have to do an amputation if we can treat that with quinoa and carrots? So we have seen some uptake. Not to the scale that I like, but it's been positive. Let's talk about trust and personal data. It was a big question that I had about my career, right? I was going from two not-for-profit organizations to a for-profit organization. Would I need to sacrifice my values? And I asked that question and was told no. You don't have to, you won't have to. I've been here 2 years, and wow, has that been consistent. It's the message that I have from the leadership at Google is make Google-size impact and go help a lot of people. And that's been the consistent message over and over and over. I've been the one who's saying, we got to create a sustainable business because we're going into healthcare, and if people think Google isn't serious and could stop it, if we're not showing some sustainability, the message from above is be helpful, help a lot of people, even to the point of, hey, don't worry about the business, we want impact. Now, that's an amazing opportunity. So that's been consistent. The personal data one and the trust question. To me, the biggest thing that I'm worried about, I feel that our technology is world-class and could save billions of years of life. The biggest thing I'm worried about is the trust. We need to have the trust of consumers, of providers, of politicians. I need to have the trust within Google. I need the trust of my team. Without it, I think we've missed a huge opportunity that every time I say Google, my phone goes off. We will have the technology will be left on the shelf, and we won't get done what we need to get done. So the trust issue is absolutely crucial. So how do we get that trust? Really, it's through partnerships. It's through saying, well, here's the best example. I was at the Royal Free, and I was seeing a demonstration. It was show and tell. I'm showing up, they're telling me about the app and stuff like this. And the nurse, her name was Mary, takes the app, the phone, and goes into a room and says to the patient, I've been coming, I'm Nurse Mary, and I'm here because your creatinine went up and I want to make sure you're okay, and shows the patient the phone. And I was like, wow, we need no marketing. If our healthcare providers, your healthcare providers, who patients trust, say to people, hey, do this Google thing, it's really helping me, or I'm using Google and it's helping me. It's like, we're done. So we need to earn your trust. And then in turn, I think that helps us earn the trust of patients. And we got to be helpful. We have to continually give them good information, make it easy for them to find what they're looking for, and answer their needs. So it's something that we spend lots of time on. We don't sell ads against personal health information. We follow all the rules around privacy and all of that stuff to the T. I mean, we're great at that. I think we have to be even better. I think we need to have a higher, because we're Google, because people talk about us as a verb, and because we started as a consumer business, as we get into this health business, we got to follow all the rules plus. And so that's really what we're working on, and look forward to working on all of you with that.
Thanks, David. I've got another group of three. So the first one is from Sarah Jones, which is health informatics certainly assists with value-based healthcare. Do you think health informatics should be the first line of inquiry, or are there more practical things that could demonstrate greater value to patient experience rather than outcomes, which aren't based on information? The second one is about is a shorter question from Richard Ross, which is how near are we to personal devices which can develop illnesses developing? And then the final one is from Sarah again, which is you didn't have very much money at UCLA, she said. So what did you change first? And in a world concerned with value, would you do the same again? And how did you ensure that the changes you made were sustainable?
I missed the second question.
So the second question is, how close are we to have early detection of illness on our personal devices?
Okay, so the first question about connecting and is it technology? No, I think connecting is a human connection. This talk would be much better if we were all in the room together, right? So I think healthcare is better. I think healthcare is fundamentally people caring for people. The technology are tools that assist in that. The technologies do not solve the problem. The problem is a human being or a group of human beings or a team of people that together have a common vision of helping an individual or a family or community. I mean, to me, that is healthcare. And the technology is spectacular because, like Dr. Marsden, the hospital helped take care of the patient. That's a technology. The technology is spectacular. It's based on trust. It's based on people connecting. So I put the human connection above anything. The personal devices, I think we're there. I think we're really at a tipping point where you will be able to, I mean, this is the way we're thinking about products. And I'm going to exaggerate in saying this, but if you're hospitalized, I see it as a failure of outpatient care. We didn't do the right stuff in the outpatient setting. If you're in the outpatient setting, I see it as a failure of home care. We didn't give you the tools you needed to care for yourself and your family at home. And if you're caring for yourself at home, it's fundamentally a failure of community care. We didn't care for your community. So we really want to build things that push things to healthy communities so people aren't sick at home and certainly don't have to go to the doctor or go to the hospital. Now that's an exaggeration, but that's the framework. So when you think of a personal device as an ability for you to care for yourself at home and not need to go to the doctor, that's fantastic. And we saw this with COVID. We saw that telehealth, which was creeping up on this slow curve, move to an entirely different curve. And it's certainly easier for people, for certain conditions, to be able to connect with their caregivers virtually. And what if we had tools that allow those virtual connections to do even more, to monitor your vitals, to be able to look at things, be able to touch and hear and see. So to us, that's really important. And we do think that that powerful smartphone that now really is almost ubiquitous in parts of the world is a potential platform for people to get that kind of care. At UCLA, we had no money. That's right, when we started. I used to tease when I left, the biggest problem I had financially was where to hide all the money, because it was amazing. Once you actually started taking care of patients, more people came. And not only did more people come, applicable to this talk, our fundraising went through the roof. UCLA happens to be in a very, very well-to-do part of Los Angeles, but a lot of those patients would bypass us and go to hospitals on either side. They started coming to UCLA, so fundraising went up, payments went up, we expanded, we really expanded to primary care and made it easier for patients to get to us. Those same-day appointments really helped. So I don't like to talk about it, but we turned around the financial situation pretty dramatically.
Thanks. So a group of three more. The first one's from Amit Bakai, who's one of our cardiologists, which is, might Google Health help match patients to the most appropriate caregiver? So you might match them to a local pharmacist when appropriate, or an international, pioneering surgeon in different circumstances. So can it help that, provide a kind of dating between the right person and the patient? The second one is from Sarah Jones again, which is, with the advance in artificial intelligence, informatics and technology, how do we overcome the digital divide to make sure we don't leave, there's not a group of digitally disenfranchised patients and public? And then the third one is from James Mountford, who used to be our Director of Quality, which is, how do we see digital and artificial intelligence impacting on the training of healthcare professionals and their basic professional role? And will they need to know different things? And will they be spending time on things we haven't thought of yet?
This is hard with the 3 questions at a time.
I know. Well, I'll maybe go down to 2 after this, because we're there'll probably only be 2 more questions. Sorry, David.
I'm teasing.
Sing your non-existent supper.
Yeah, so matching patients, yes, we are trying to match patients. We're just starting this in the US. It will come to other places. In the US, one of the big issues is, does my insurance cover this doctor? So those are one of the things we're starting to roll out, but also the type of doctor or space. And we've already done it with COVID, that 7%, I think it's 7% of patients before, no, I'm sorry, 70% of patients, I think that's the right number, before they go to an emergency room, or what you would call A&E, I think that's what it's called, do a Google search within 24 hours. Now, a lot of visits to A&E or to emergency rooms could be handled in other settings. So we're trying to give people information not only to what's the right doctor, but also the right type of setting to go to. Could this be handled by urgent care? Is there a telemedicine availability? So we are just starting to roll that out now, starting in the US. And in the US, it has this other work stream around insurance verification that really helps patients, because they don't want to be surprised when they go to the doctor and that's not covered. So yes, we're trying to match. The digital divide, we're super concerned about. We're doing work with in India and Thailand around diabetic retinopathy. We continue to focus our work in other parts of the world. And the digital divide, another way we think we can get at it is, if that community health worker has an Android phone, that can actually help a lot of folks. So even if those folks don't have that type of technology yet. And then the last one around training, sorry, there's noise here in my background. The last one around training, we think it's super important. I've talked with deans of medical schools, both here and outside of the US, about how do we get AI training into medical school now, because I think what's going to happen as these softwares become medical devices, you're going to want to know how they work and how to ask the right questions, and are they right for this population. So there's a bunch of, you don't need to know how to code, but you need to know how to ask the right questions about the tools to make sure you're doing things the right way. So yeah, I think we do need to get it into training, and would love to talk further about that.
That's brilliant. We'll close it with two last questions. We've got 7 minutes, and that gives time for some closing remarks. So the last 2 questions is actually I'm doing them in reverse order, because I think that the first one's a better closing question. So the first one I'll ask is from Jenny, which is she absolutely agrees that trust is an issue in relation to artificial intelligence. and she's heard comments in relation to COVID contact tracing. The COVID contact tracing app was people wouldn't use it because they didn't want big tech or the government monitoring their every move. So how do you overcome that? That's probably back to some of the trust stuff earlier. And then the last question, which I'm very interested in the answer to, is again from Amit Bakai, which is, how does Google make decisions about what you do, about how you know, because you could do hundreds of things, couldn't you? So how do you decide what to focus on in health solutions? We'll do that as the closing one.
Great question. So the trust one, which we talk a lot about, I think we've gotten some really positive outside press and folks saying that we did do this app with Apple in the right way. It's privacy preserving and it's voluntary, etc. Of course, it only works if people want to do it, and if you don't trust tech or Apple or Google or whatever, we got a hurdle to overcome. We did it because we were really being asked by public health to do it, and the real app that you're downloading is not a Google or an Apple app, it's somebody else's app. But that doesn't matter if people still don't trust us. So this is the way that I'm thinking about it. When you use Google Maps, you are telling Google that you're starting at home and you're going to go to your friend's house. You're telling them you're leaving now, and you're telling them all along the way where you are. What does Google do in return? Google tells you turn in 15 feet, turn left, the destination's on the right. Would you like to stop at a coffee shop on the way? Every turn that you make, we're adding, I hope, disproportionate value to what you've given us. So if we take that into healthcare and we say, are you going to share health information with us? In this case, just location data, which actually we don't keep. We need to give more value than the perceived amount of information you're giving us. So if you tell me you're sick and you have cancer, what can I do so that on that journey of cancer, I'm giving you information that's disproportionately larger than what you've given me? In the same way I think our maps does it. So that's how we're thinking about it. How can we give you more value than what you're giving us? And then you build trust. Then you're like, oh, these people are being helpful. So this one isn't going away. We got to keep working on this one. We will make mistakes, but we're committed to getting this one right, because I think without this one right, we should take our games and go home. I just don't think it works without trust. And then finally, how do we focus on what to do? Wow. That's been a big question for me and the team over the last couple of years. So it's got to have Google-sized impact. Well, I'll give you an example of what we decided not to do, and I think that will give you a little bit of an insight into it. So our machine learning and AI in healthcare in America, a lot of how you get paid is how sick the patient is. So are there things you could capture in the record that would make the patient sicker from a coding standpoint that would drive better revenue? I'm like, look, I didn't come to Google to improve coding, right? So we take those things off the table. What we were, and I'm not saying that coding isn't important, but that's not a Google size problem. So we want it to be Google size. We want it to be a world issue. And then we want it to be complementary to our other platforms. So we're good at organizing information. So when you think about what we're doing, not only do we want to get more authoritative information on YouTube and search and get people to the right information, we want to help organize information for individuals. That's what we're trying to do on the consumer side. Organize information for communities, right? That's the core of Google, is around taking messy data and making sense of it. And on the clinical side, it's bringing that amazing technology that could tell you, yes, that's a Labrador Retriever, or what kind of flower you're looking at by computer vision, or what kind of kitten, and saying that's a breast cancer, or that's a problem with your skin, or doctor, when you are thinking about anticoagulation which is a blood thinning, on your patient right now and looking in the record around anticoagulation, our technology knows that you're likely also thinking about Coumadin levels. The same way when you do a search and you're looking for a couch, you may be often looking for a love seat, right? So what can we do to use that technology to help organize information for doctors and nurses to make it easier for them to do their job? So is it Google size? Does it fit with our surfaces that we have, whether that's Android phone or search or YouTube? And I hope I brought this to the team. And then we are positive that we can't do this alone. You cannot fix healthcare by yourself. This is about partnership. This is about partnerships with places like the NHS that are willing to say to us, okay, let's do all the right stuff, privacy and trust-wise, but we need to learn this together, and we need to do this through you. In essence, we are here to serve you, particularly those of you that are caring for patients directly, to make your life better. So then it's an iterative process. So it's through partnerships. And Google as a company is a partnership company. When you really think about the different platforms, it isn't a closed ecosystem, it's an open ecosystem. So that's how we make the decisions. They're actually really tough. There's been a bunch of projects that I think are amazing that we don't have the resources or we don't have the bandwidth that we've decided not to do. There's other bets we've taken that I'm sure we'll look back and think are the wrong bets, but our guiding principles are, we want to add years to everyone's life and life to their years. And so that's how we're thinking about it, and how can we get those big wins.
That's brilliant. Thanks, David. I'm really sorry. We've got a terribly hard cut-off at 7 o'clock, so I'm going to have to draw things to a close because we could talk all night. It's been absolutely brilliant. The patient focus, the kind of the kind of rigor about it, and the fascinating insight into what Google and others are up to. So it's been genuinely been a privilege to hear it. We could have had hundreds more questions. I've had a question come in from Stephen Powis, who's my predecessor, about misinformation and vaccination and how Google might have a positive role, which we'll probably take up at another point. I just want to make three thank yous. Firstly, I'd like to thank I'd like to thank the charity, particularly Judy, who's been absolutely instrumental in our new way of doing this, which I think makes it much more of a kind of program of brilliant things rather than a one-off event. So thank you very much to Judy for her vision. The second is to thank David Sloman for his introduction, but the most important thank you is to David Feinberg, who's been absolutely outstanding. And if this was a lecture theatre, it'd be full of applause now. So thank you very much, and good night to people. Thank you.